Hi, everyone. My name is Dr. Jess Calohan, and I am the chair of the Psychiatric-Mental Health Nurse Practitioner Department at Frontier Nursing University. Today, I'm going to talk about psychological first aid strategies that providers can use to help manage crisis situations with their patients. I think we would all agree that the current COVID-19 pandemic meets the criteria for a crisis situation. So the evolution of psychological first aid, it was really developed as an acute psychological intervention to support first responders. It was eventually adopted by the military and used in many different types of iterations. The first iteration that the military started to use was called critical incident stress debriefing. And this was an opportunity after a critical event or disaster event or whatever you want to call it, whatever type of crisis event had occurred, that we would debrief the participants and help them begin to cope with what they had to deal with. That led to the Mitchell model, which was effectively a 7-stage process that further defined critical incident stress debriefing, and the participants had to work through these 7 phases of the debriefing. The problem with this particular model was that it was often re-traumatizing. Psychological first aid was developed by the National Center for PTSD and National Traumatic Stress Network and is now utilized and taught in many behavioral health programs across the country and is used by first responder organizations, the military, and even healthcare organizations, large healthcare organizations that have trauma centers. From an evidence-based practice standpoint, it was discovered that the critical incident stress debriefing in the Mitchell model actually did more harm than good. It essentially re-traumatized people and further encoded their emotional responses and psychological responses to the traumatic experience or the crisis experience that they went through. The psychological first aid model puts a little bit different spin on it, and the focus is purely on being supportive. It doesn't re-traumatize individuals. It doesn't make individuals go back and think about the situation, describe the situation. The focus is purely on supportive to help people make sure that they are meeting their basic needs. Because if people aren't meeting their basic needs during crisis situations, the stress reaction is going to continue to persist. So when we look at trauma or crisis situations in general, it is a 100% normal reaction to a very abnormal situation. The early symptoms of trauma have a significant impact on Maslow's physiological and safety needs. And so for all of you, we all should be familiar with Maslow's hierarchy of needs. Anytime we've kind of had somebody experience a traumatic event or groups of people experience a traumatic or crisis situation, oftentimes their support systems are ripped out from under them, their world is flipped upside down, and basic needs usually go along with that. So the focus of psychological first aid is again supportive, that helps to reestablish people meeting their own physiological and safety needs. The goal of intervention is to reduce the long-term impact of trauma and return the individual to the pre-level or baseline level of functioning before the traumatic event. So the psychological first aid model is focused on not reliving or processing the trauma. It's focused on engagement, support, safety, stabilization, needs assessment, education, on coping, information on collaborative support services, and then where to get additional help if it's needed. So let's talk about safety and comfort. As you can see, this very much parallels Maslow's hierarchy of needs. The person has to be in a safe environment. Okay? We want to make sure that they're in a safe environment. And when we look at the current situation with what's called social distancing, or something that one of my colleagues brought up is really more physical distancing, we want to make sure that people are in a safe environment and that they are having their physical comfort needs met. Additionally, when it comes to these other safety and comfort needs, there may be spiritual needs or other needs that people are looking for that they find that helps them be very comforting. So in terms of spiritual needs, we have to get a little creative, particularly in these circumstances, and assist people with different ways to access their spiritual support systems. One of the other things that I think is important is that sometimes we as providers feel like we have to do something for people, especially if they seem to be, or if they seem to be very emotional related to crisis. And oftentimes what I have found is that my urge to do something might make the situation worse. And so I prefer to just be there for the person, just be there, let them talk, let them emote, and let them kind of process the situation. Because if we try to intervene and do something, we may not be as helpful as we think we're being. So I like to call it just be there with them. Just be still, be quiet, let them process what's going on. And then we can take pieces of it after they have been able to process things, and we can figure out how we can best support them, okay? We are not going to fix all of their issues. So we have to prioritize is what resources can we leverage and what things can we do to help them. And again, we really need to be focused on those first two rungs or stages of Maslow's hierarchy of needs. Stabilization. Use very simple statements for these individuals. And if you are in treatment centers or you're in places where people are being evaluated, making sure that people have access to food and water, maybe while they're waiting to get tested, or if they've already been diagnosed, or your clinic or unit or whatever is effectively housing more people than what you're used to. We're talking more of a mass casualty type situation. And remember, you cannot rationalize with people that are irrational. All right, and that's where the simple statements come in, and that's where the just being component comes in. Is we have to be very, very direct. We also have to remain as calm as we can, and we have to meet them where they're at emotionally. If sleep is an issue, we can use short-term medication to help people sleep. Sleep is a core symptom of people that have had significant stress or trauma reaction. And if we don't treat the sleep, there's going to be a long cascading of events or symptoms that are going to impact the patient. So if somebody isn't sleeping and they are very emotional, they haven't been meeting their basic needs, that's something that we can do. Before we over-pathologize and start jumping into use of other medications and other types of therapy, I like to treat their sleep and then see kind of what's left over and see if we truly do need to provide additional services, additional support. And like I said, just meeting them where they're at is so essential in this situation. Again, this kind of goes along with that, gathering information about what their current needs are. In certain circumstances, this may be kind of outside of our realm in terms of where they're going to stay. We may be leveraging other support staff around us to help them with that, particularly if people are in homes where family members have been quarantined due to being ill. Where are those family members going to go? Leveraging our social support services and those types of organizations. If people are having a hard time locating their loved ones, or if they're sick, what types of services can we offer or help them in locating that loved one? Are there folks that have lost people? What sort of support do they need for that? What sort of resources are available? What's their current psychological state? Are they in a state where they're experiencing extreme guilt or shame or thoughts of self-harm? Probably less so with this particular situation. This is more so with a disaster response or traumatic event, where maybe I'll use an example of a provider or a first responder that felt like they should have been able to save a person they were working on, but they didn't, and they experienced guilt or shame. And really, if people are experiencing those levels of guilt and shame, that is a red flag that they may be considering self-harm. It places them at higher risk. And I see that a lot in the veteran population that I've worked with, and also with first responders. What are their coping mechanisms? What type of coping mechanisms do they have? And are they adaptive or are they maladaptive? Is this person somebody that has a previous substance use disorder? And what are some things that we can do to help support them in their continued recovery and sobriety, and reinforcing positive coping mechanisms? A polytrauma history, this is really more for that direct interaction where you're seeing somebody, and if they have a polytrauma history, that places them at higher risk for having more long-term or mental health symptoms that are likely to need more than just meeting some of those basic needs at this point in time, meaning they're at higher risk to have more longer-term consequences for the impact on their mental health, and will likely need some form of treatment, whether that's pharmacological, psychotherapy, or a combination of both. Assistance, what are their most pressing needs? We may not be able to address all of their pressing needs, but I often ask people in crisis, okay, you've mentioned a lot of things to me today. What are the one or two most important things that you want us to address today? And I can help frame that up depending on what it is. And if we're able to focus on that, it helps give them some sense of hope. It reestablishes hope, and it helps give them some semblance of control in a situation where there's a lot of unknown and loss of control. What's the plan for addressing the needs? And then how do we assist them in addressing the needs? Social supports, very important to identify and leverage existing support systems. We know that people that don't have solid support systems or access to support systems have worse outcomes when it comes to long-term consequences of mental health issues as it relates to crisis or traumatic situations. Talking about how they can seek help, where they can seek that help, and what the type of help is that's out there. Right now, again, this is an unprecedented situation that we're dealing with the physical distancing. It's hard for people to go to their healthcare provider. It's hard for them to leverage social support networks. So we want to help them identify alternative strategies to redefine their social support plan and how they're going to interact with those that are in their social support network. Coping, we don't want to over pathologize the reaction. We want to let them know, hey, what you're going through related to this particular situation and circumstances is absolutely normal. It's a normal reaction to an abnormal situation. We can talk about what are the expected reactions, what are things that people can experience. They can experience sleep disturbance, they can experience irritability, they can experience anxiety, they can experience appetite changes. They can experience depression. They can experience a lot of different types of things. And what our focus is on how to manage those situations and letting them know that some of these things will gradually get better. The concern is when they don't get better. And if they don't start to get better, rather they start to get worse, then that's a sign that they need to be reaching out for more assistance. Reviewing the positive coping skills that they have used in the past to be successful, and what are some of the things that they can do to meet their basic physical and emotional needs. In terms of collaboration, we really should try to assist them with resources for services, getting them connected. Right now, I know there's a lot of services that are online where people can get emotional support via text or over the phone or via Zoom or those types of things, and what are those resources in our community. The other thing is providers. We can even if our patient's not in crisis, but they're worried about coming in to seeing us, what are some of the things that we can do to help with adherence to medications and those sorts of things. And I would say that we can give them if appropriate 90-day supplies of medications with refills. Encourage them to use their mail order pharmacies. As long as that infrastructure is still in place, which there's no reason to believe that it's not going to be in place, they can still get their medications. I, for example, have quite a few patients that are very concerned about getting their medications and being able to see me. And we have staff that are in place to reach out to them. We've increased our use of HIPAA compliant email, and communication with patients through email, and also HIPAA compliant text platforms. There's a lot of different types of things that are relatively inexpensive that we can do to help our patients mitigate some of the stress that they're dealing with during this situation. And then again, if needed, if symptoms are getting worse and we feel like they need more services, we can generate and try to coordinate referrals, but knowing that we may need to put some stopgaps in place because it may be a while before they get into those services. And so what are some, again, alternative plans, telebehavioral health, those sorts of things. And then providing points of contact to first responders and support organizations, and identifying ways to promote a sense of community. And I think that's one of the things that's been very unique about our community here in Frontier and us doing these webinars is we're reaching out to our community and we're rallying around our community and we're encouraging people to be part of our community. And those are the same types of things that we can take out to our local communities that we're serving and provide that support and guidance. And quite frankly, that's what a lot of our local leaders that aren't healthcare providers are looking for. And so this is an opportunity for us to be experts in our field, to demonstrate how we provide sense of community and provide role modeling to those leaders in our community so that we can come up with the best way to support those that are in the most need. All right, so the key points of psychological first aid is don't over-pathologize. We don't want to re-traumatize the person by having them telling us about all the stuff that they went through. Again, we do want to make sure that they have access and facilitating basic psychological and emotional needs. And like I mentioned before, just be there. Sometimes just being is all that they need for that emotional support. If you have questions about this presentation or other strategies, feel free to reach out for me. And thank you so much for watching this presentation.